Now we're going to continue with the next major theme of today's program. The next session focuses on one of the most influential forces shaping the future of healthcare: artificial intelligence in pediatrics. This panel will explore the current state of AI across Europe and its application in pediatric care. We will bring together perspectives from hospitals, startups, and supercomputing facilities to examine both the challenges and the extraordinary opportunities ahead. It is my pleasure to introduce the moderator of this session, Pekka, Kahri, Development Manager in the Strategy and Development Unit at HUS, Helsinki University Hospital. Pekka works at the largest public healthcare provider and academic medical center in Finland, one of Europe's leading institutions in health data use and AI adoption. He is also the coordinator of FEMS, a major Horizon Europe project that aims to foster cross-border data collaboration between European pediatric hospitals. And now, our panelists. Leah Butler, Director of Marketing, Sales, and Business Development at NeoPredics AG. Leah leads commercial strategy and business development for predictive and AI-driven healthcare innovations, helping accelerate technologies that support clinicians and improve outcomes for women and children. David Torrents, leading researcher at the Barcelona Supercomputing Center, a biochemist and molecular biologist with a PhD from the University of Barcelona. David worked at EMBL Heidelberg before becoming an ICREA research professor at the Barcelona Supercomputing Center. He leads the computational genomics group, focusing on biomedical genomics and the links between genomic challenges and disease through bioinformatics and AI. And finally, Dr. Yolima Cossio, Data and Digital Transformation Director at Sant Joan de Déu Barcelona Children's Hospital. She is a specialist in preventive medicine and public health with a PhD in global health. Dr. Cossio is a recognized leader in digital health transformation with extensive experience in strategic leadership across major hospitals. She now leads digital and data transformation at Sant Joan de Déu. Pekka, the floor is yours to begin the discussion.
Thank you very much. Thank you, and thank you very much for the invitation to join the Pediatric Innovation Day again. It's a pleasure. It's the third time for me attending, and I hope that there will be many more. As we remind that this is an innovation event, and reminding what does innovation in healthcare in fact entail, it's not only about scientific discoveries, but it's something that is taken into use in the healthcare provision, and something that creates real, measurable patient benefits or healthcare provider advantages, or at best both. So for me, scientific article is not an innovation, it's an article. For me, the demo of an AI product is not an innovation, it's a demo. But when it goes into real use, in a real environment, and leads into benefits for patients and healthcare provision, then we can talk about innovation. And innovation is hard because there's a tricky path from invention into innovation. But I think that this is the work that we have to do, and as a community for pediatrics, we can advance things that come from the scientific world, from the technologies that are being developed, so that they come to bedside and benefit our patients and the healthcare provisioning. Adoption of artificial intelligence solutions in healthcare is surprisingly low. So let that sink a bit. There is so much happening around artificial intelligence, but what we see is pilots that are encouraging, we see demos that are inspiring, but then how to scale it up, how to take it into routine use that would benefit the patients in large scale. There's something that doesn't, the last mile is somehow missing. And I think that this is a topic we could and should discuss when we talk about artificial intelligence. the amount of projects that there are, the amount of funding, the amount of big tech push around artificial intelligence is staggering. We are overwhelmed by that. But how do these solutions reach the bedside? That's maybe one of the topics that we could discuss today with our panel. So the promise is there, but clearly there are some gaps. Especially with machine learning and also generative AI, there seems to be some sort of adoption gap of trustworthiness and sustainable adoption. So even though there are pilots or demonstrations that seem to work, there is still a lack of evidence. How does this work in large scale? What are the benefits? And can we afford, or is the value for money there for our patients and for our healthcare delivery? Also, there are questions about the real clinical usefulness, robustness of these solutions. How do they behave over time when they're used routinely in massive healthcare environments? Big concerns are, of course, bias. Are the algorithms somehow potentially biased? And a solution for bias is often said that you need to train and validate the algorithms with lots of data from different parts, and then the gap might be access to data. How do you access these data which are there? And then, of course, there are regulatory things that are uncertain in a new field, and there might be also some tech barriers. So the infrastructures in the hospitals might be not ready to adapt artificial intelligence in large scale. My perspective in this topic is really about access to data. So I said I work in a large European Horizon Europe funded project called FEMS, where our partners include San Giovanni de Deu Hospital, Erasmus Medical Center, Gosh in London, Mayo Children's Hospital in Florence, Riga Clinical University Children's Hospital in Latvia, and several technology partners. And our thing is to try to create a collaborative effort in improving access to data. That's maybe one part of the bridging the gaps that there are. Of course, we have to remind that pediatric data is really special. It's specific. Children are a small part of the population. It's divided in age groups that make the population groups even smaller in numbers. Parents are intermediating the data. We don't get into hospitals maybe enough data about healthy children, because majority of children are healthy. How do we address that gap? But I think that our need is to somehow urgently enable these works in a European context, and i4Kids and the networks of the pediatric hospitals in Europe is a wonderful platform for that. So with this framing of the discussion, I would now give the word to our panelists for their introductory statements, and maybe starting with Dr. Yolima Cossio from San Giovanni de Deu Hospital. So you are Director of Data and Digital Transformation. So please share us your perspective and approach the topic of the day's panel.
Okay. Thank you very much. There is quite a lot of things to talk. I don't know if we will have enough time. I want us to start saying that the role of a doctor that has the responsibility for the strategic chain of digital and data is quite important in the hospital, because basically we have a lot of researchers, we have a lot of doctors and nurses who have some clinical interest, but also we need to hear the patient, what the patient needs. But we need to combine that with the organizational priorities. Sometimes we miss these two topics, and also to match all of them with the technology opportunities. I think that one of the reasons why sometimes we cannot scale pilots is because we don't see this three perspective. There's someone who comes with a fantastic idea for this part of the attention, but probably it's the no more important or not the key problem for this population, for this hospital, or maybe it's not where we can put the investment at this time. Then I think to have this overview of what are the needs of all the ecosystem are quite key to determine that the pilots can scale from a real digital transformation and that we really can change the life of our patients. Just to start.
Thank you, Yolima. Thank you. And then next, I'll give a word to Leah Butler. So she's the Director of Marketing, Sales and Business Development at NeoPredics. So Leah, go ahead.
Hello, everybody. Thank you for having me today. I'm very excited to be here with all of you in this, room of like-minded, progressive thinking individuals. And I think it's really necessary that we all come together to contribute to, to the creation of tools that will undoubtedly lead to pediatric innovation. And one of the really important things, of course, is access to data and building tools that leverage that data to, from my perspective, forecast the risk of different health conditions that are absolutely predictable, preventable, and give us the ability to be proactive instead of reactive. And so I think that it's really important that we create frameworks in order to access that data and bring it all together to create these tools and AI, machine learning tools to advance pediatric innovation.
Thanks, Leah. Would you like to elaborate a bit? What do you do? What does your company do? What is the product that you are providing?
Sure. So NeoPredics, the company that I'm representing, is we're a predictive analytics company, and we forecast the risk of various health conditions under the maternal, neonatal, and perinatal umbrella. And so we have two solutions on the market, both CE certified and FDA cleared, one of them is. And one of those products is our jaundice predictor. And the idea with that is to reduce unnecessary treatment, testing, and procedures, and really identify which patients are good candidates for early discharge and who's a good candidate to go home early. Same thing with our preeclampsia predictive tool. It's not necessarily pediatric. However, preeclampsia often leads to a pediatric problem. And I'm an example of that, actually. And that's what was the catalyst that led me to sitting here today. Is I unfortunately fell into one of healthcare's greatest blind spots, which is rapidly advancing preeclampsia, which was missed. And had we had a predictive tool like we have built through NeoPredics, I wouldn't be in this position that I'm in today with a very testy cardiovascular system and having had to experience a traumatic birth and watching my children in the NICU. So I'm very proud to be representing this company who is now advancing innovation in this space.
Thank you. Then third panelist, David Torrents, a place we visited yesterday with the Pediatric Innovation Mission, Barcelona Supercomputing Center, and you are a research professor there. So
yes.
Please, your introduction.
So thank you very much for the invitation. It's also very nice to be here. I was going to more or less summarize what you said, basically. So the basic challenge, I come from the research part, public research part, so very early in this chain of events. And basically the bottleneck right now is the access to data. Also what we commented in when we talked, the communication between the technical and more biomedical or clinical communities. Communication is not still well, it's not working perfect, let's say. And then, as you said, at the end of this chain, the implementation and to detect bias, regulation, and how it's implemented because of this type of tools is also critical. So it would be these 3 points. I think those are my concerns. The rest, it's just doing things.
Yeah. If you want to elaborate a bit, if you see from your perspective as a scientist, so where are the biggest opportunities in healthcare or in medicine where you see that AI truly can change things? Because it's clear that it has some potential. It will not change everything, that's for sure, but there might be somewhere it's more lucrative. How would you see those? Where are the areas?
So from my perspective, again, is the access of data. So everybody should be aware that most of the AI research is not done at the hospitals. Many doctors in the hospitals are doing research, but most of the AI is done outside of the hospitals. But the data does not go outside. So, and this is one of the big bottlenecks. Hospitals, for me, should start applying other type of dynamics with the data, and also going into the kids area and more rare diseases also. This is even more necessary because one of the approaches to analyze, rare diseases, I come from the genomics, so from the genomics perspective, they are quite easy, and please don't misunderstand me, misinterpret me, but they are quite easy. You get it with an exome, you can diagnose at the level of gene, they're quite easy. So the problem here are the pathology itself and the biochemistry and the molecular biology. And as you said, the statistical power that we need for AI tools is big. And in this case, you have small groups. So that's why I think it would be necessary to start coordinating different experts on different diseases or disease areas and start grouping in different ways and start testing with these different groups. That would be a way to overcome these limitations. But the access of data is the key point here.
Yolima, how would you like to react on what David is saying? What are your thoughts from the hospital perspective? You are the person who is leading data and transformative activities.
Thank you. Thank you to give me the opportunity, because basically David is breaking my heart with all this idea how you cannot access the data, but it's completely true. I think that things are changing now. I think that previously the data were in silos, and the owner of the data were the researchers that collect that in Excel or another kind of infrastructure. Now we could see, and the hospital are more aware, the need of have a transversal direction or transversal team that have the governance of the data, aligning all the needs of all the researchers, but also the clinicians, because every time that you need to take a decision, the limit between if it's research or if it's clinical decision is smaller and smaller. Then some team that have the capacity to identify the needs, to organize the data, to have the quality of data, and to have the tools to share that is something that is building. In our hospital, for example, we have a governance office data that have all the process. We are aware of what are the needs, then we start to construct the infrastructure to get the registers into the electronic medical record and to put in a place where it will be available for the researchers. Saying that, I think that we have an amazing opportunity now with the European data space. European health data space give us the principles of governance to make easier to share all this data cross-border. Then as a hospital and as a network, we need to be quite ready for all these new rules. Because so far, if we not prepared, what's gonna happen is that other institutions, for example, private companies, gonna do the intermediary between the who needs the data and who are the holders of the data that are the hospital at this moment, at least from a point of view. Then I think that all this idea of European health data space need to help us to organize internally, to be absolutely prepared for next year when they come here and say the data is not available. We say, yeah, it is, with all the rules the European Commission decide.
Thank you, Yolima. Leah, how did you manage with your product development and going into market? You have a product now. You have used data to develop that product. How did you solve the data access question? And don't say that you went to the US to do that.
Yeah, well, I think we're a good example. We did a little bit. I'm sorry, but I think we're a good example of what happens when you have access to clean, good data, and we saw that in our partnership with the Mayo Clinic Platform Accelerate. We had access to a large data set there, but it was also clear that it wasn't quite diverse. And so, we then had to purchase data from elsewhere. And again, wonderful data sets that allowed us to create solutions that are now on the market, but it was a long and difficult road. And so we are definitely proponents of having consortiums or, where you're doing it here with EHDS, right, where you're supporting cross-border data sharing. And I think it's really, really important that we continue to do that and move in that direction so we can continue to build these tools at a much faster pace and get them in front of patients.
But you have a CE marking for your product.
We do, yeah.
So did that require that you had also European data somewhere, and how did you manage that part? Because we know that it's more restricted, more complicated than in the United States.
Yes. So obviously there are lots of qualifications that we need to meet, and and accessing European data is one of them. But I'm happy to share that we met we reached our CE certification and have a very robust quality management system that has helped us ensure that our tools meet all the quality and standards and data standards that are needed in order to come to market. And because of that, we actually now can become our own notified body, and we have a special CE marking that allows us to bring our additional or future algorithms to market much quicker, and we can self-certify in the future.
Yeah. That's really an interesting and inspiring case, because that might give, again, we need hope, and we also need hope for the entrepreneurs that are working with solutions for healthcare technologies and medtech. So thanks for sharing that. Sure. David, Yolima already referred to that there's need for governance and also maybe some infrastructure, but there is like spectacular infrastructure in the scientific field. How do we combine these capabilities that there are for science and make them somehow accelerate the adoption into real-life healthcare? Is there a way? How do you see it?
Yes, well, there are some political frames that I'm not going to get into because they're complicated. Administration, the BSc is a public national center, so then we have limitations acting as a company sometimes, and people from innovation are here, so they know about this. So we have limitations. At the level of research, again, the limitation is the access to data. The rest is there. We have the technical people, we have the capacities, and right now the Mare Nostrum, the Barcelona Supercomputing Center, is used very intensively with many AI projects, not only directed on biomedicine, also on earth science and computing science. So yes, again, we have to have to fill up those machines with data, but I think the machinery is there. It's true that, again, the communication between different communities is not easy. Technical, I'm biologist, molecular biologist, so I had to learn. I'm bioinformatician, so I know how to, now I accept this, but I know how to talk to an engineer or how to talk to an informatician. But that was not the first time. And the BSc is actually a very nice environment because we have common language, and we more or less got over those early limitations. Yeah.
Okay. Yolima, how do you see that this gap between the engagement or common language between clinical teams and hospital staff and the scientists and the computational people? How could we address this topic, or is it something that you are already working with? And if you have some examples, so happy to hear those.
Yeah, I think that first of all, the multidisciplinarities are quite important. I think that there is no doubt about that. Before, we think that the hospital was just nurses and doctors. Slowly, we started thinking in other disciplines like physiotherapy, nutrition, etc. Now, it's impossible to think in a clinical team without them. My point of view is that we need to incorporate and to include another cut of science in this discussion. It's not just to have a data manager, it's not just to have an engineer as a good people to be close to. We need to start to think as a core of the business, not just as an enable teams that are there if they are there, with working conditions that are different to the rest of the team. Because now I think that to help with the diagnosis, with the treatment, the STEAM professional, science, technology, engineers, art for designers, mathematics, all of them has to be part of the clinical teams. And I think that this is quite a revolutionary concept because in the organization, we still seeing all these kind of professionals, some help, some support, direction. But my proposal is not just to have a multidisciplinary team that they come to a meeting eventually, but that they be absolutely involved with all the development. Then what are we doing in the hospital and the culture of the Hospital San Juan de Deo is basically that we incorporate these people in the clinical team, and we design the solution based in the needs, but also seeing what is the real workflow. Then there is what I call cross-contamination, and come from the epidemiologist field. This is a beautiful cross-contamination where you could see doctors speaking about Python, and you can see engineers speaking about risk of infection. Then it's quite nice to see that.
Yeah, one chief physician in our hospital once said that the recipe for AI move forward is to clinicians and data scientists in the same kettle and cook medium heat. So not too hot, but definitely not too cold.
Cold, yeah, that sounds nice.
Brilliant. But if continuing with where do you see then this topic of creating evidence that these really solutions that come forward are really useful? How do you see in the hospital's perspective as suggestions come to your desk? What should we be doing? What should we be investing in? How do you see the topic of generating evidence about clinical value, but also the value for money? How do you approach that in your hospital?
Our route of implementation of the AI is divided in three areas. Basically, what we find, not just in this hospital, but in my previous work, is a lot of frustration of the people with the promise of the hype of technology. Then they say, don't worry, you're going to have the data, you're going to have algorithms that predict everything, then AI will support you in all the decisions. But this is the red area of the European law of artificial intelligence because it's the medical device that helps with diagnosis of treatment. Then we're fighting quite longer to make these algorithms and to put into production. Then in this long way, the doctors, the clinician, and the people who are working in this algorithm were quite frustrated. Then what we are doing now is divide in a green and yellow zone to make that quicker, to speed up the evolution of the AI. Then in the green area, we're just working with operational tasks that AI can help all our process, not just the diagnosis and the treatment process. Now, what we could see is that with simple solutions like a chatbot that doesn't have any risk for the patient, improve the efficiency of the hospital or the results, then people get engaged and say, oh, that's real. Oh, it can solve this little problem that I have, but it's now easier and easier. Then people get engaged. Then we can show quickly results that can say that, okay, then all this department of data really is working for helping with my day-by-day task. Then in that way, we are constructing all the red area and being a lot more robust to also speed up all these implementations. I don't know if I answered your question with that.
We'll leave that to the audience to decide. But Leah, for you, when you work with new customers and you're bringing in your solution or product to them, how do you support or engage in this process of crossing from interest into implementation and adoption and taking into use? What kind of things you do as a company to support that?
Well, it starts pretty early on, I think, and that's through enlisting multidisciplinary teams to ensure that your product is has product market fit and you're building something that the market wants, something that's safe, efficient, effective, and actually solving a problem and a need to have, not necessarily just a nice to have. So we start there. And then from there, when we begin to introduce the product, a lot of times we're met with maybe some fear around adopting AI tools or technologies. And I remind them that our tools, as they sit in the EMR, they're not self-learning, they're not active AI, they are static. And so once they're created in there, there's really no risk that, you know, this robot is going to come out of somewhere and make bad decisions for your patients, right? And so we ensure them that it's safe. And then, you know, from there, we remind them that these tools are clinical decision support. So they are meant to make, help you make more informed care decisions and just provide you with additional data for that. So you still have autonomy to make your own decisions, but these tools are incredibly helpful. And the truth is, and Dr. Halamka said this out of the Mayo Clinic, he said, you know, AI will not replace clinicians, but it will replace those who don't use it or those who don't have AI literacy. And I really believe that, and that's really inspiring to me. And sometimes I talk to our potential customers about that, and I'm slowly and surely seeing a shift, and there's a lot more comfort and openness to bringing in these tools. So I like the direction we're going here.
Then a final round of things, you know, what would be your call to action? What would you really like to see happening in this field to take the adoption of development of AI in healthcare forward? And what would be your stake in it? You know, what would you be doing yourself? So maybe starting with David.
Oh, that's yeah, that's a tempting question. Yes. So I think if we really want to see at the speed that we are seeing that everybody's promising, we want to see a change, we have to change several things. And among those is the culture around the data. The concept of data ownership, this has to change. It's true that European health data space will save the place, I don't know, but actually I was in the first phases, I was with the Commission working in the first phases of European health data space, and it was not supposed to be like now it is more directed to giving the patient the final decision. It was more about let's make it public with some control, but let's make it for research, of course. This has been changed during 10 years of elaborating this European health data space. And now this part is not mentioned. So this is because of the culture behind data ownership and data sharing, which is, I think, one of the bases. The rest is just technology and it's just putting money and but the culture is very difficult to change. And the question I always, when I discuss this topic, in this case is what is best for Abril, Nora, and all the Abrils and Noras in the world. And the best is to open and share the data.
Thank you. Yolima, what would be your call for action? What needs to do and what would you be doing in your future months and years?
I'm definitely agree with David that change the culture is the biggest issue. And to help to change this culture, I think that we need to raise evidence. My advice and the call for action is to show that all these projects can convert from shiny pilots to really transforming healthcare. And for doing that, what we need is to have data to show the return of investment in evidence, in economically, but also in outcome for the patient. Then this is my advice.
Brilliant. Leah, what would be your call for action?
So in an ideal world, I think that we would have greater access to funding dollars. As we know, that's a huge problem. And so we need money in order to create. And for us, you know, data is difficult to access, but we find it. It's really finding the dollars to continue, which is really hard for us small fish sometimes. But also on top of that, I think collaborating with other like-minded companies who are also developing tools that are complementary can be really powerful. And I think strength in numbers is really important.
Thank you very much. Thank you all for your insights and your call for action. My call for action is really related to the same topic of access to data and data sharing. I think that the European health data space is a truly exceptional initiative, providing hopefully a common legal framework. But I think that it is not enough. I think we have to work with what I would call a pediatric health data space for Europe, so that we are already before the EHDS mechanisms and all the authorities are in place, that we start working first in a federated manner. So not moving data around, but in a federated manner, and creating useful tools for clinicians first to do simple things like benchmark with their colleagues cross-border, and then develop and create the evidence for their usage of new tools, normal algorithms, advanced algorithms, different types of topics. But I think that we need to do it. We can't wait anybody else to do it. We have to do it ourselves. Thank you very much for the panel discussion. Thank you for the audience for listening. Excuse me.